Now we will see with the continuation of the trachea. The trachea is we cannot say it is a rigid tube. Actually, the collapse of trachea is prevented by this C-shaped cartilage. Okay, this trachea, it bifurcates at the T4 level of the vertebral body, thoracic vertebra. So this trachea comes down and bifurcates in the into right and left bronchus. Then finally it is entering into the hilum of the lung. The entry point of bronchus into the lung is called as the hilum of the lung. If there is a lot of importance for this mucosa of the trachea. There is a lot of importance for mucosa of this trachea. If you see, this trachea is having C-shaped cartilage. It is this cartilage prevents the collapse of trachea, and in the posterior aspect of the trachea you have the esophagus. Sometimes there are chances for formation of fistula between this esophagus and the trachea, tracheoesophageal fistula. Okay, because this esophagus is running in the posterior aspect of the trachea. So this is the lumen of the trachea, and the mucosa of the trachea is also very important because it is special nature, because it is made up of pseudo-stratified ciliated columnar epithelium. Actually these cells are columnar epithelial cells. Okay, but it is pseudo-stratified. Stratified means multiple layer. Pseudo-stratified means false multiple layer, because these cells are so closely packed so that the nucleus are arranged adjacent, so it resembles like a multiple layer of cells, but it is a single layer of cell. Okay, and it is ciliated column. Cilia means there are hair follicles like this. You can see there are hair follicles on this. So this cilia keeps oscillating, and it will be pushing this mucus towards the mouth. It will not allow the mucus to pass towards the alveoli. That's the speciality of this pseudo-stratified ciliated columnar epithelium. Underneath you have the lamina propria, which is a connective tissue. Then you have the cartilaginous layer, and then you have the adventitia layer, the outermost layer you can see here. Okay, so this is there are more number of globular cells which has the ability to secrete the mucus, Okay, so these are the globular cells, and that is present in the under the surface of this epithelium. Okay, then the submucous layer has the seromucous glands, which we call it as a lamina propria. Okay, which is also rich in the lymphocyte cells. Okay, and below that you have the hyaline cartilage. This hyaline cartilage will be absent at the posterior side. That's why this is a thick C-shaped cartilage. We call it as a C. The shape is like a C shape. This is a C-shaped cartilage. The trachea is having around 14 to 16 or this many number of C-shaped cartilage is present. Okay, so the outermost layer is the adventitia, which is where the C-shaped cartilage is present. And now let's go with the conducting zones. Let's go with the conducting zones. That is the respiratory zone. That means the areas where the respiratory gases pass. Respiratory gas is passing. Okay, functionally the respiratory zone is divided into conducting zone and the respiratory zone. Conducting zones are nothing but where the oxygen and carbon dioxide travels. Okay, it starts to travel in the nose, then comes to pharynx, then comes to larynx, then trachea, then bronchus, bronchioles, and then terminal bronchioles. Okay, now if you see this trachea here, this is the T4 vertebra. This is the T4 vertebra where the bifurcation of the trachea is taking place. Okay, where the bifurcation of this is the place where the bifurcation of trachea is taking place, the T4 vertebra. Okay, so there is something called Lewis angle. If you go deep into anatomy, you have to study about Lewis angle. That it's not included in your syllabus. Okay, so you see these are the C-shaped cartilages, and it is dividing into the right bronchus and the left bronchus. Suppose if I drop a foreign body, a small peanut or any coin, it comes and inserts to the right side, because right bronchus is more wide and it is more towards the gravity. Okay, whereas left bronchus is small and it is tilting against the in parallel with the again, I mean, it's not towards the gravity. So maximum chance to the foreign body to land is the right side. Okay, the right bronchus is broad and it is more wide also. Okay, so this junction is called as a carina. Okay, this is more sensitive. Any foreign body comes and touch this place, severe amount of cough reflex is generated. Okay, and this bronchus enters into this area is called as a hilum of the lung. Okay, not only bronchus, the pulmonary veins also enter here. You see, this is the this is the pulmonary veins that is entering into the then the pulmonary arteries. Okay, this is the pulmonary artery that is also exiting. Pulmonary artery is also exiting. So this is called as a hilum of the lung. So this area is having more lymphocyte area, lymph nodes. We call it as hilar lymph nodes. Okay. So after entering into this, this bronchus, primary bronchus divides into secondary bronchus. The secondary bronchus divides into tertiary bronchus. Okay, these are the tertiary bronchus, which is also called as the segmental bronchus, and segments of the lung I will discuss now. Okay, just know this is how the bronchus is bifurcating. This is how the bronchus is bifurcating. Okay, this is how the bronchus is bifurcating. So the respiratory zone is nothing but the place where the actual respiration is, gases exchange is taking place. This is taking place in the alveoli. Where is this alveoli? So if you see further branches of this tertiary bronchus divides into bronchioles. It divides into bronchioles, you see, and these are all the bronchioles. Okay, and there are smooth muscles. These are nothing but the smooth muscles that is present around the bronchioles. Okay, these smooth muscles gets irritated and it narrows the respiratory tract. Okay, when this smooth muscle gets irritated, what happens? It constricts the bronchioles and it causes bronchial asthma. That is what we call it as bronchial asthma. So what happens? The bronchioles are constricted and then the patient is able to breathe in, then he is having difficulty to expire. Okay, so what we do, we give bronchodilator drugs like salbutamol, then terbutaline. There are many classes of bronchodilator drugs. So then we dilate these muscles and the respiratory passage becomes free. Okay, so these bronchioles, it ends in the air pockets. This is called as the alveoli. This is called as the alveoli. Okay, so on this alveoli you have the capillary beds. Okay, that is spread, and this is the place where the exchange of gas is taking place. That is from the RBC cell, the oxygen will be picked from the alveoli, and the carbon dioxide in the RBC cell will go into the alveolar sac, and during expiration that goes out. Okay, so this is what you have to understand as a respiratory zone. This is what you have to understand as a respiratory zone. So these are all the conducting zones, that is from the nose, trachea, primary, secondary and tertiary bronchus, and then till the alveolar sac. Okay, so now this primary bronchus is the main bronchus, secondary bronchus is lobar bronchus, and the tertiary bronchus is called as segmental bronchus. Okay, so then the segmental bronchus divides into bronchioles. Now coming to the conducting zones, the bronchial trees includes terminal bronchus, respiratory bronchus. The tissue walls of bronchus mimic that of a trachea. As conducting tube becomes smaller, structurally changes occurs. Then the cartilage support structure changes, epithelium type changes, and the amount of smooth muscle increases in the bronchiole level. Okay, so here you can see these are all the bronchioles, the smooth muscles, and finally it ends as a air packet, that is alveolar pores. It's called as alveolar sacs. Okay, so you can see this alveolar sacs is made up of squamous epithelial cells, which allow the easy exchange of diffusion of gases from the capillary beds, capillary beds. Okay, so the bronchial subdivisions are the terminal bronchioles that consist of cuboidal epithelium, have a complete layer of smooth muscles, then lack cartilage. There is no presence of cartilage in the bronchioles. There is no presence of cartilage in the bronchioles. Okay, so this area is the respiratory zone where the exchange of gases is taking place. Okay, the respiratory zone is defined by the presence of alveoli, begins as terminal bronchiole, feeds into respiratory bronchioles. Respiratory bronchiole leads to alveolar ducts, then terminal clusters of alveolar sacs composed of alveoli. These alveoli are non-functional in the intrauterine life. Once the baby is born, the septum in the heart closes, the ligament ductus arteriosus fuses, and when you clamp the umbilical cord, then immediately a negative pressure creates that leads to closure. 7 physiological changes is taking place during the time of birth. Okay, then that time we make the baby to cry. When the baby cries, what happens? The baby takes a deep breath and all the alveolar sacs expands. Okay, baby should cry once the baby is born. If the baby is not crying, we pinch the baby or we tap the baby in the gluteal region to make the baby to cry. Okay, so once the baby cries, that time the expansion of alveolar sac is taking place. Okay, the expansion of alveolar sac is taking place. So now the respiratory membrane, you see this is the alveolar sac and this is a capillary bed. So what happens here? The oxygen from the alveolar sac is coming picked by the RBC. The deoxyhemoglobin is giving the carbon dioxide. So this is how the exchange of gas is taking place. This is what we call it as a respiratory zone. This is made up of cuboidal epithelial cells, and this process is called as a diffusion. Okay, so there are approximately 300 millions of alveoli and accounts for more total volume of the lung. It provides tremendous surface area of gas exchange. You know what? Study is telling that 10% of alveoli is enough for normal perfusion of oxygen during rest. Okay, so in normal adult human life we are exposed to dust, we are exposed to smoking habit, we are exposed to lung disease. Then also these alveolar sacs, they keeps damaging, but 10% of the alveoli is enough to perfuse enough amount of oxygen for the body at the time of rest. Okay, so when this remaining all the alveoli damages, there are many chances for damage. Okay, like lung disease, dust environment, many diseases are there. So we go for concentrated oxygen. Some old patients who have severe chronic lung disease, they sit in the house with the oxygen mask and they will be having continuous oxygen supply. So this oxygen supply will is going to help the patient to have enough amount of oxygen. Okay, so in fact when you go high altitude, the oxygen level is less, so your heartbeat is less, your hemoglobin level in the blood increases, and you also breathe fast in the beginning stage. Later you get adapted, your body gets adapted to it. Okay, so this is the place where the alveolar sacs, where the capillary oxygen exchange is taking place. The carbon dioxide from the hemoglobin comes to the alveolar sac, the oxygen from the alveolar sac go picked by the RBC cell and it takes to the body, and it is taking it to the body. Then let's go to the bronchi and the subdivisions. Okay, so in the alveoli there are two types of cells. One is type 1 epithelial cells that allow gases exchange by simple diffusion, and also it secretes angiotensin converting enzymes. Okay, you know what, this is very important phenomena you have to understand. Okay, angiotensin converting enzyme secretion by the type 1 epithelial cells. Okay, this increases the surface tension. Okay, so the surfactant secreted by type 2 cells increases the surface tension in the alveolar sac, thereby it helps the air sacs in alveoli to be stable and prevents collapse during exhalation. Okay, so that is called as surfactant. Okay, keep in mind, Type 1 cell is secreting ACE, that is angiotensin converting enzymes, and type 2 cell is secreting surfactant that prevents the collapse. So if the surfactant is less, the lung alveolar membrane will start to collapse. The alveolar membrane will start to collapse. Okay. Now, the alveoli is surrounded by fine elastic fibers, contains open pores that connects adjacent alveoli, allows air pressure throughout the lung to be equalized, houses macrophages that keeps alveolar surfaces to be sterile. Okay, so this is important. Okay, so what happens, these are the elastic fibers. Okay, so when in the capillary beds, when the RBC is traveling, they give carbon dioxide and pick oxygen molecule and go back to the heart, and they are going back to the heart. Now coming to the lungs and the pleura, there is two lung, right lung and the left lung. This is right lung and this is the left. Okay, right lung has 3 lobes. I will show you this. The right lung is having 3 lobes. This is upper lobe, middle lobe and the lower lobe, whereas in the left lung you have only 2 lobes, upper lobe and the lower lobe. These lobes are further divided into segments. There are 10 segments. Okay, in the upper lobe we divide it into apical, posterior and anterior segment, whereas in the middle lobe we divide it into lateral and medial segment, whereas in the lower lobe we divide it into apical segment, anterior basal segment, lateral basal segment, posterior segment and medial basal segment. So likewise there are 10 segments in the right lung, whereas in the left lung we have only 9 segments. Okay, you have the upper lobe and lower lobe. In the upper lobe you have apical and posterior segment, and then anterior segment, superior lingular segments and inferior lingular segments, whereas in the lower lobe you have apical segment, anterior basal segment and medial basal segment, lateral basal and posterior basal segment. Okay, if you see in this picture, the different colors are there. These colors are given according to this segment. Okay, for you don't have to remember about segment because it is not present in the slide, but for your clinical point of view, you have to exactly locate in which segment the abscess is present, in which segment the tumor is growing, in which segment the lung is having inflammation, or in which lobe the lung is having inflammation. You need to read the X-ray accordingly. Okay, so you have to know that there are lung is divided into upper lobe, middle lobe, lower lobe, and those lobes are further divided into segments. You have 3 segments in upper lobe, 2 segments in lower lobe and 5 segments in the lower lobe. So 2 segments in the middle lobe and 5 segments in the lower lobe. Likewise in this for left lung also 4 segments in the upper lobe and 5 segments in the lower lobe. Okay, so if you remove a lobe from the lung, we call it as lobectomy. If you remove one lung completely, we call it as pneumonectomy. Okay, so this is what you have to understand the terms here. Okay, so the lung occupies the thoracic cavity, and the space between the 2 lungs is called as a mediastinum. The space between the 2 lungs is called as the mediastinum. Okay, so these are all the horizontal fissures and the oblique fissures that divides the lung. Okay, now what you have to understand here is about the covering of the lung. We call it as the pleura. Okay, so the lung itself, the superior area we call it as apex, and the basal area we call it as a base. Okay, this is the base and this is the apex. Okay, so the intercostal muscles are present between the ribs, but there are intercostal artery, vein and the nerve that is running in between these muscles. I will show you that. So coming to the blood supply of the lung and pleura, the lungs are perfused by 2 circulations, pulmonary and the bronchial circulation. Pulmonary arteries that are bringing the deoxygenated blood from the right ventricle to the lung, whereas the pulmonary veins carry the oxygenated blood from the lungs towards the left side of the heart. Okay, towards the left side of the heart. Coming to the bronchial arteries, they provide lung with oxygenated blood. They are branched from the thoracic aorta. Okay, so supplies all lung tissues except alveoli. The bronchial veins are connected to the pulmonary veins. Okay, so the blood supply for the lung is different, whereas the blood supply for the perfusion is different in the lung. Okay, so coming to the pleura, you have two layers of pleura, the parietal pleura and the visceral pleura. Okay, so if you see here, I'll show you. Okay, this is the parietal pleura. Okay, you see, this is a parietal pleura. I hope you can see now. This is a parietal pleura, and when you remove the parietal pleura, this pleura is the visceral pleura. This is the visceral pleura. This is the visceral pleura. Okay, the visceral pleura is running in between the fissures. Okay, the visceral pleura is running in between the fissures. Okay, so when you open the thoracic cage, when you hold the lung, you are holding the visceral pleura. Okay, so in between this parietal and the visceral pleura, you have the pleural space. This parietal pleura is like a serous membrane. And it will secrete a pleural fluid. Around 100 to 150 ml of pleural fluid is present in the pleural space in order to lubricate these surfaces between the parietal and visceral pleura. Why? Because during inspiration the lung will expand and the visceral pleura will touch the parietal pleura. Okay, so in order to prevent the friction, the fluid is normally present. Okay, that's called as pleural fluid. About 100 to 150 ml of pleural fluid is normally present. Okay, so if this pleural fluid is dry, it is not secreted, then parietal pleura and visceral pleura will rub each other and they cause friction pleuritis. That leads to friction pleuritis. Okay, so the parietal pleura, it covers the thoracic wall in the inner surface and superior face of the diaphragm, continues around the heart and between the lung. Visceral pleura, it covers the external lung surface, divides the thoracic cavity into three chambers: the central mediastinum, lateral compartment, and also containing the lung. Okay, now pleural relationship with thoracic cavity. Now we are coming into actual physiology. of the lung. Now there is something called spirometry. I will show you. I think it is there in the slide. I will show you the spirometry. You know what? First of all, you have to understand the respiratory pressure. Okay, so the respiratory pressure is always described relative to atmospheric pressure. Okay, atmospheric pressure, we mentioned it as P, that is ATM is atmospheric pressure in the atmosphere. Okay, respiratory pressure exerted by the air in surrounding the body. Okay, atmospheric pressure affects lung volume affects respiratory pressure. Okay, the body changes the atmospheric pressure in the alveoli by changing the volume of the lung. As volume increases, respiratory pressure decreases. As volume decreases, the respiratory pressure increases. Okay, so I will show you here. This is the atmospheric pressure, that is 760 millimeter of mercury is atmospheric pressure that is going inside the trachea. Okay, now I have shown you a video like when the diaphragm contracts. A negative pressure is created, thereby this lung will expand. Okay, so this pressure inside the thoracic cavity is managed by this diaphragm. When the diaphragm contracts and becomes flat, the pressure will increases and this lung will expand. Okay, so this pressure here is intrapleural pressure. This pressure here is the atmospheric pressure. Okay, so whenever the diaphragm contracts, a negative pressure is created, that is -4 millimeter of mercury is created in the pleural space, thereby the lung will expand. Please see the video that I showed you in the beginning. The person is pulling the balloon, that is a diaphragm, that creates the lung to expand by the negative pressure created in the pleural space. Okay, so for that, this thoracic wall and the diaphragm should be airtight. For that, the diaphragm and the thoracic wall should be airtight. Okay, now let us see the mechanism of breathing. So negative respiratory pressure is less than the atmospheric pressure, that is -4. Positive respiratory pressure is greater than the atmospheric pressure during the time of expiration. Okay, intrapulmonary pressure, we mentioned, is alveolar pressure minus pressure within the alveoli, that is the pressure inside the alveoli. Intrapleural pressure is the pressure in the pleural cavity, inside the pleural cavity. The pleural cavity, we mention it as PIP. The alveolar pressure, we mention it as PALV. The atmospheric pressure, we mention it as PATM. Now, if you see, the fluctuate the pleural pressure fluctuates with breathing. Okay, the pleural pressure is always negative related to the alveolar pressure. Okay, so this pressure you see here is always in negative compared to the pressure present in the alveoli. Okay, then only the lung can be prevented from the collapse and the exchange of gas is normal. Okay, this negative pressure is increased by the contraction of this diaphragm. This negative pressure is increased by the contraction of this diaphragm. Okay, this is what you have to. So that this negative pressure allows the lung natural tendency to recoil. Then the surface tension of the alveolar fluid, the amount of fluid in the pleural cavity remains minimal. Okay, why? This pleural cavity fluid is lubricating the surface of the lung. Okay, whenever there is more in some chronic disease conditions, what happens? There is more collection of fluid in the pleural space. We call it as hydrothorax. Okay, sometimes if there is a hole in the lung or in the thoracic cage and the air escapes into the pleural space, we call it as pneumothorax. Okay, sometimes the pus fluid, the abscess that is present inside the lung will break and that starts to drain into the pleural space. We call it as pyothorax. So these kind of things happens in the tuberculosis. Okay, so the pleural pressure, the total pressure is the pressure difference between the alveolar pressure and the pleural pressure. Okay, so the PTP is equal to pressure in the alveoli minus the pressure in the pleural space. Okay, it is not the actual pressure because the intrapleural pressure is negative. The TP is usually a positive value, that is the atmospheric pressure. Okay, the size of the atmosphere determines the size of the lung at any time. The greater the total atmospheric pressure, the larger the lung will expand. Okay, the intrapleural pressure equalizes with atmospheric pressure and the lung will collapse. So make sure that always negative pressure has to be maintained in the pleural space. Okay, so what you see here is when we puncture the thoracic cage, what happens? This pressure becomes positive or equal to the atmospheric pressure, then the lung will start to collapse. The lung will start to shrink. Okay, this is what we call it as pneumothorax. So what happens? You make a hole, the air will start to collect in the pleural space and it will start to collapse the lung. Okay, that's called as pneumothorax. We call it a tension pneumothorax. The tension pneumothorax is life threatening. You see the apex area, it will be swollen. Okay, I will try to show some picture. See, here is a normal x-ray. Okay, a normal x-ray here. You see in the x-ray, this is apex and this is the base of the lung. Okay, and this is a cardiac shadow. Okay, this is a cardiac shadow. We call it as cardiac silhouette. Silhouette means it's English word, the shadow. Okay, so this length from here to here, here to here, and here to here, all this should be 3:1. Okay, if this length is not matching, maybe there will be left ventricular enlargement. That is cardiothoracic ratio to see the, and this is the trachea. It comes here in the midline and it bifurcates. Okay, generally when there is pneumothorax, the tracheal shift will be present, or if there is chronic lung disease, the tracheal shift will be present. Okay, so this is a normal lung x-ray. This is a heart shadow and this is the lung shadow, and these are all the bronchovascular markings. Okay, so here in the pneumothorax, what happens, and there is accumulation of air, more amount of air that is compressing the whole lung. You see, this is what we call it as tension pneumothorax. To save this, you see the lung is completely compressed and air is accumulated due to one-way leakage. So to save this patient, you have to make intercostal puncture and relieve the air. Otherwise, the lung collapse will take place and the patient will die. Okay, now let's go to the mechanism of breathing. Okay, in mechanism of breathing, there are three things: inspiration, expiration, and the pause. So during the time of inspiration, what happens? The diaphragm will contract. Okay, then the thoracic cavity will increase, the lungs are stretched, and then the intrapulmonary pressure drops and the gases exchange is taking place. Okay, even the there are two types of movement for the ribs: bucket handle movement and the pump handle movement. Okay, during inspiration expiration, this movement is taking place in the thoracic cage. Okay, so all this inspiration is by the contraction of the diaphragm that I have shown you before. Okay, next, expiration. So what happens during expiration? The diaphragm will relax, the pressure will drop, and you will try to breathe the air out. Okay, inspiratory muscles will relax, that is the diaphragm. The rib cage descends due to recoil of costal cartilage. Thoracic cavity volume decreases, elastic lung recoils, then intrapleural pressure rises and becomes positive, intrapulmonary pressures. Okay, then air flows out of the lung. Okay, so this is what even the diaphragm, the rib cages will shrink in the like a pump handle movement. Okay, so this is what is happening in expiration. Then this inspiration and expiration is followed by a pause. This is a respiratory cycle. Okay, this is a respiratory cycle. Okay, so the intrapulmonary pressure is the pressure inside the lung decreases as the lung volume increases during inspiration. The pressure increases during expiration. This pressure. Okay, intrapulmonary pressure. Whereas the intrapleural pressure, this is the pleural space. This pleural pressure is the pleural cavity pressure becomes more negative as the chest wall expands during inspiration, returns to initial value of the chest wall, recoils. Okay, then the volume of during each breath, the pressure gradient moves 0.5 liters of air in and out of the lungs. Okay, so actually we call it as a tidal volume. That is the thing I will explain now. Okay, now coming to the airway resistance. What are the physical factors that is influencing pulmonary ventilation? One is airway resistance. The amount of gas flows out in the alveoli is directly proportional to the p value. So small changes in pressure causes large changes in gas flow. Gas flow changes inversely with resistance. The greater resistance occurs in the medium sized bronchi. The terminal bronchioles, a gas flow stops and diffusion overtakes. Examples: pneumonia and pulmonary edema. Okay, in case of restrictive airway disease, These kind of changes physiological changes you can see. Then physical factors influencing pulmonary ventilation. So what happens, what the factors that is disturbing the pulmonary ventilations are this constricted bronchus. There are smooth muscles in the bronchioles, and they will constrict and cause spasm, and they narrow the bronchial passage. Okay, so thereby what happens, the patient is able to inspire but expiration becomes difficult. This is what happens in asthmatic attack. Okay, this can be due to some sort of allergic reactions by pollen dust. Okay, when the pollen dust is causing allergy, this bronchospasm is taking place. Okay, likewise, when there is some smell, some people will not like smell of fish, something that also can cause allergic reaction to bronchospasm. Then psychologically induced bronchial asthma is there. Okay, sometimes in some family, when daughter-in-law sees mother-in-law, she gets asthma because she gets psychologically disturbed, and that leads to bronchospasm. Okay, they stare at the mother-in-law and they start to get wheeze. Okay, so these are all psychologically induced. Okay, so epinephrine release via the sympathetic nervous system dilates bronchus and reduces air resistance. Okay, so we have to send this bronchodilator drug through this to act on these walls. Okay, so that's what the role of the bronchodilator drug. Then alveolar surface tension, as I told you, the type 2 cells in the alveoli that is secreting a substance called surfactant. Okay, that maintains the surface tension. Okay, what is the surface tension? It is the attraction of liquid molecules from one another at a liquid gas interface. That is the place where the gases exchange is taking place. Liquid coating the alveoli surface is always acting to reduce the alveoli to smallest possible size. There is a fluid called surfactant. This reduces the surface tension, which means the fluid stretch and act as a surface tension to hold the air and gas over fluids. Okay, then lung complaint. The ease with which lung can be expanded is called as lung compliance. The lung compliance is a measure of volume that occurs with the change in the pulmonary pressure. Okay, a given transpulmonary pressure depends on the lung compliance. It is determined by two main factors. One is distensibility of the lung and the surface tension in the alveoli. These are the two factors that makes the lung work effectively. Okay, highly compliant stretchable and disturbance ability to stretch. Decreased compliance means this happens in the pulmonary fibrosis. Okay, the stretching property of the lung is lost in pulmonary fibrosis, and the smoking capacity, in smoking the lung stretchable property is increasing. Okay, that's why in the future gradually the lung function is reduced for the smokers. Okay, also highly elastic. Compliance is opposed by elasticity and surface tension in the alveolar fluid. There should be a balance between elasticity and compliance. Okay, so factors that diminish lung compliance are the fibrosis of the lung, blockage of the lung by either can be asthma or something, then reduced production of surfactant in the alveoli, and decreased flexibility of thoracic cage or its decreased ability to expand. So this can happen in cardiac surgeries. We open the thoracic cage and lungs flexibility can be decreased. Okay, then reduced production of surfactant can take place for people who are chronic smokers. Okay, blockage of respiratory passages take place in bronchial asthma. Scar tissues can be formed in case of tuberculosis infection or lung abscess or any other lung diseases. Okay, the disease that affects the lung. These are all the factors that decreases the efficiency of lung function. Okay, so coming to this summary, I have to tell about this volumes. Okay, there is respiratory volume and the respiratory capacity. See, overall 5000 liter ml of gas can be accumulated in the lung tissues. So I will explain this with this. Okay, so this is the total lung volume, that is 6000 ml for, sorry, not 5000, 6000. You know, when an average adult inspires maximum amount of air, we call it as total lung volume, that is 6000 ml. Okay, then the from the 6000 ml of lung volume, I mean, we have functional residual capacity, respiratory volume, and vital capacity and total lung capacity. Okay, so both your lung can hold up to 6000 ml of gas. Okay, vital capacity is the amount of air that you are able to breathe in and breathe out. That is what we call it as vital capacity. Okay, so inspiratory capacity is the maximum amount of air you are able to inspire after normal expiration. Okay, that is 3600 ml. Expiratory capacity is after normal expiration, the maximum amount of air that you are able to breathe out, that is around 1200 ml. That's what we call it as expiratory reserve volume. Okay, the inspiratory reserve volume is the tidal volume. So the tidal volume is the amount of air that is going in and coming out during normal respiration, that is 500 ml. Okay, inspiratory reserve volume is the amount of air you can able to inspire with the tidal volume. Okay, with the tidal volume. So they may ask this formula with you. That is, Vc is equal to IRV plus TV plus ERV. That is the vital capacity. Total lung capacity is equal to IRV plus the FRV, functional residual, inspiratory capacity plus the functional residual capacity. See, this is very simple. This is what we call it as a spirometry graph. Okay, spirometry is study of lung function. Okay, imagine two lungs there. You are able to breathe in 6000 ml. That's what we call total lung capacity. Okay, but you are able to breathe out and breathe in after you fully expire. We call it a vital capacity. Okay, so for example, if a patient is not having having any lung disease, then the vital capacity will reduce. Okay, so you have to know this term. Inspiratory reserve volume is 3100 ml, tidal volume is 500 ml, expiratory reserve volume is 1200 ml, residual volume is 1200 ml. So the functional residual capacity is 2400 ml, inspiratory capacity is 3600 ml, vital capacity is 4800 ml, total lung capacity is 600 ml. So just take this photo in your brain, don't take in your mobile. So if you take this photo in your brain, you can explain the complete lung function. Okay, so next we will go about the hemoglobin. I have told you about oxyhemoglobin and the deoxyhemoglobin.